So what is the real world in treating patients with a aortic dissection? Usually it's not expected. So either you or your patient have been somewhere else outside of the hospital, and then there is this emergency scenario. For instance, we had very recently a 62-year-old female patient having experienced a syncope, and for that reason being admitted on an emergency basis to the hospital. And when the CT scan was performed, it was already close to 10 p.m. And what we saw on the CT is a typical dissection type A. Is actually, it's a massive dissection. You can see a near to collapse of the true lumen in the ascending aorta, also a narrowing of the true lumen further down, and the 3D reconstruction shows you a typical DeBakey type 1 dissection. Upon arriving in the operation room and prior to incision, we see the extent of the dissection, and more importantly, we already can see some pericardial effusion and regurgitation of the aortic valve as a result of the dissection. This is quite typical for what we do and what we see in our practice. So what is the operative strategy in such a case? Well, we in Düsseldorf, and I think same is actually the case for many other centers, have something like a common standard for this kind of patients. And the standard is to replace the ascending aorta and to do the distal anastomotic line in cardioplegic arrest and circulatory arrest at mild or moderate hypothermia. We use usually 26 to 28 degrees of Celsius. And this is done under selective antegrade cerebral perfusion. Some of us use unilateral. Personally, I prefer bilateral perfusion. And we do this. Why do we do that? We do this in order to avoid the fatal intraprecardial complications. Now, occasionally, we will have to do more than the standard. And this will concern either the aortic root or the aortic arch. For the aortic root, in our center, and treatment is usually triggered either by extensive dissection, but we have the feeling that gluing the root is not a good idea, particularly in the very young one. And the other indication is, as you could see on the TE, is a relevant dysfunction of the valve. Towards the aortic arch, there is actually a lot of debate when and how to treat. Our policy is, when we see a tear in the aortic root, we have to address that. Oh, sorry. On the other hand, we can do that in different steps. You can extend the distal anastomosis towards zone 1, 2, or even do the total arch replacement with or without an elephant trunk. Nowadays, with the elegant devices providing frozen elephant trunk. However, you have to keep in mind that technical complexity considerably increases with these steps, so going from left to right. And along with this, also the risk for the patient increases considerably. And this is actually across all major registries the case, no matter in the European registries or even or also in the North American. And this is just one result from one publication. This is a German registry on aortic dissections, and you can see the 30-day mortality increasing from 16.5 to 22.3% when we extend the operation towards the arch. So the question is, when and how do we increase the risk for mortality by increasing technical complexity and still can control over operation times, bleeding risk, all together in order to prevent late complications? And in my opinion, this is the gap in knowledge actually, because we still do not have an optimal surgical approach with an ideal trade-off between these two components. On the one side, the operative risk, and the other side, the long-term perspective for the patient, the long-term prevention of late complications. So here is when the Cyrus medical dissection stent comes in.